Bismillahirrahmanirrahim. So now we are going to start the next session of our CVS unit. So there is a Uworld point that left lateral decubitus position increases the intensity of which murmur? The answer is mitral stenosis, mitral regurgitation, and left-sided S3 and S4. So here we saw that for the murmurs to be like audible, S3 and S4 heart sound when we were talking about that. So we saw that the position must be left lateral decubitus for the S4 as well as for the S3. Yep, left lateral decubitus position. So left lateral decubitus position allows the heart to come closer to the chest wall. So all the murmurs that are heard at the mitral area, for example, the mitral stenosis and regurgitation along with S3 and S4 heart sound, they are better auscultated when you put the stethoscope on the mitral area with the patient in the left lateral decubitus position. NBME point is that inspiration will increase the tricuspid murmur because it is a right-sided murmur, and expiration will increase the mitral murmurs because it is left-sided murmur. And we had a very extensive discussion about inspiration and expiration. Now moving forward to the Kaplan-Eubank point, that is inspiration increases the negative thoracic pressure, that increases the venous return. This increase in the venous return is going to increase the blood in the right ventricle. That will lead to pooling of the blood pooling of blood in the lungs. That decreases the systolic arterial pressure. Why so? Because if the blood is pooled inside the lungs, so there will be a decreased backflow of the blood or decreased return of the blood to the left atrium. And if lesser amount of blood is moving to the left atrium, so lesser amount of blood is present in the left ventricle. So lesser amount of blood will be pumped into the aorta. Simple math. So there is a decreased systolic arterial pressure. Got it? So the decreased systolic arterial pressure will be sensed by the body system, like sympathetic nervous system and the kidneys, and that will result in an increase in the heart rate. And that increase in the heart rate will cause decreased left ventricle and diastolic pressure and increased right ventricle and diastolic pressure. So now moving forward, I guess it is a thing like decreased left ventricle and diastolic pressure. Like at the end of the diastole, the pressure is reduced, but the left ventricle and diastolic pressure is reduced directly because of inspiration, and the right ventricular and diastolic pressure is also increased directly because of inspiration. And why is heart rate? So I guess heart rate is increased because of decreased systolic arterial pressure, and these two things are direct effect of that. Maybe. Now moving forward, auscultation of the cardiac murmurs. Now firstly we'll talk about Valsalva maneuver. Valsalva maneuver has two phases. First one is the strain phase, that is the early part of the Valsalva, and that we have the late phase, that is release phase. Okay. So in the early phase, the venous return is decreased because of increased straining phase. The venous systems are compressed and there is a decreased venous return to the heart. All the murmurs will be exaggerated except for the hypertrophic cardiomyopathy. All the murmurs will be decreased. So there is a decrease in all the murmurs except for the hypertrophic cardiomyopathy and mitral valve collapse. They will be exaggerated. The murmur of the hypertrophic cardiomyopathy and mitral valve collapse, they will be exaggerated. Now we'll see that the murmurs that get louder, these are hypertrophic cardiomyopathy. Why so? When there is decreased left ventricular volume, the gradient is increasing. What's the meaning of that? Now suppose that here we have a heart. The heart looks something like this and this. So here you have the interventricular septum. In the atrial septum and interventricular septum, in the case of hypertrophic cardiomyopathy, there is isolated hypertrophy of the interventricular septum. Here we have the atria and then ventricles. So forget about that. There is a thing that we call aorta, and the aortic valve is also present over there. This hypertrophic interventricular septum come in the way of aortic outflow tract, and that can obstruct that. So whenever the left ventricular volume is decreased, resultantly the flow is decreased and the obstruction becomes exaggerated, because obstruction will be relieved if there is excessive flow, and the excessive flow is causing the pathway to be opened and to be widened, and that will decrease the hypertrophic cardiomyopathy murmur. We'll see that in great detail when we do the pathology section, but right now keep this in mind that whenever there is decreased left ventricular volume, the gradient, the difference in the pressure in the ventricle and the aorta becomes higher, because in the aorta, suppose we have pressure of 120, right, and in the left ventricular and diastolic pressure, that is somewhat near like 25 or something. So and now on top of that, if we have decreased left ventricular blood flow and left ventricular and diastolic pressure is decreased further, so maybe it has come to 20. So there is a pressure difference of 100 millimeters of mercury, or that is just for the analogy. I'm just speaking about the hypothetical terms. You may take it that the difference between the left ventricular and the aortic pressure gradient increases, and the increase in the gradient will exaggerate the hypertrophic cardiomyopathic murmur. Then let's talk about mitral valve prolapse. So mitral valve prolapse is basically a condition in which we have myxomatous degeneration of the mitral valve leaflets. And if the left ventricular volume is decreased, the prolapse is increased. Why so? Just think of it as an analogy, because this is something that I was thinking for a very long time and now I just came to understand. Or you may say that I created an analogy to make it understand for myself. So suppose this is the left heart, left atrium is over here, and then we have the left ventricle, which looks something like that, and then we have the aorta coming out of the left ventricle. So in between these two areas, we have a valve that is called as mitral valve. So let me remove this thing. So the mitral valve has two cusps, that is the bicuspid valve as well. It is also called as the bicuspid valve. Now these two cusps are looking like this, and they are, uh, they are attached to each other. In the case of mitral valve prolapse, there is, in the case of mitral valve prolapse, there is myxomatous degeneration of the cusp of the mitral valve, either one or both of them. So that will result in the prolapse of this mitral valve whenever the ventricle starts contracting. Got it? So whenever the ventricle is contracting, the cusp will prolapse. This cusp will come something like that. It is prolapsing into the atrium, into the left atrium, whenever the ventricle starts contracting. Now, if we have decreased left ventricular outflow tract, if we have decreased left ventricular volume, or maybe you may say that mitral valve prolapse murmur is also getting exaggerated. Yeah, you may say that either there is decreased left ventricular volume and the gradient is so high that the blood cannot easily move into the aorta, so it starts moving to this tract, to this pathway. That is easier pathway for the blood to move, and there is exaggerated mitral valve prolapse, and that exaggerated mitral valve prolapse will cause an exaggerated murmur as well, right? The same is true for a lot of other conditions. We'll see that mitral regurgitation. So think of it like that. It is an analogy which I have created for myself, that if the blood volume is less and the gradient of pressure is high between the aorta and the ventricle, so the blood cannot move in that direction, so it starts moving towards the mitral valve, and the mitral valve prolapse is exaggerated, so is the murmur. So the two murmurs which are exaggerated by the Valsalva maneuver, specifically the early strain phase, so these are hypertrophic cardiomyopathy and mitral valve prolapse. Okay, so in the late phase of Valsalva, there is increased venous return, and all the right-sided murmurs will be exaggerated. What are the right-sided murmurs? The tricuspid stenosis regurgitation, pulmonary stenosis, and regurgitation. These are the right-sided murmurs. They become exaggerated. Okay. Murmurs that get softer. All others decrease flow through the stenotic or regurgitant valve during the strain phase. So now this was during the strain phase, and this is also during the strain phase. All the other murmurs will get softer because there is a decreased flow through the stenotic or regurgitant valve during the strain phase. So this is the reason that during the strain phase, most of the murmurs become softened, except for these two, which are hypertrophic cardiomyopathy and mitral valve prolapse. When you are standing, there is a decrease in venous return, similar to the strain phase of Valsalva, because when you are standing, the blood starts pooling into the lower limbs. It does not pool as such, but you may say that because the venous return is decreased to some extent, and that is similar to the strain phase of Valsalva. Now again, if it is similar to the strain phase of Valsalva, so there are two murmurs which will be exaggerated for the same reasons which we previously have seen, that is hypertrophic cardiomyopathy and mitral valve prolapse. Hypertrophic cardiomyopathy because of decreased left ventricular volume and increase in gradient, and mitral valve prolapse because of decreased left ventricular volume and increased leaflet prolapse. All other murmurs will be softened because of decreased flow through the stenotic or regurgitant valve during the strain phase. Now talking about squatting. So squatting is when you attain this posture like this and this and this, and here's your head, and you are doing the squatting in the gym or maybe somewhere else. So this is the squatting posture. So there is an increase in the venous return because when you squat, the lower limb veins are being compressed and the venous return is enhanced. Okay, increased afterload by kinking of the femoral artery. So there are two things that are happening simultaneously. There is venous return enhancement because when you contract your muscles, the muscles compress the veins and the venous return to the heart is increased. Secondly, the afterload is also increased because when you are flexing your knees, or when you're flexing your hips and your knees, where the hip joint, the femoral artery is compressed, and so the afterload is increasing, and increased reverse flow. I guess reverse flow is towards the heart, maybe. So there is increased reverse flow. The murmurs which will be exaggerated are aortic regurgitation, mitral regurgitation, and ventricular septal defect, because these are the areas. Because when there is increased venous return, there will be increased blood flow through the regurgitant aortic or mitral valve, or through the ventricular septal defect, that is from the left side of the heart, left ventricle to the right ventricle. So there is increased blood flow. So that is why these murmurs are exaggerated. But the softened murmurs will be hypertrophic cardiomyopathy and mitral valve prolapse because of exact same reason. So this is an opposite condition, that These murmurs came here and these murmurs came here because now we are having an increase in the preload and decrease in, because of increase in the preload and maybe also increase in the afterload. Yeah, okay. So hypertrophic cardiomyopathy is softened because of increase in the preload. There is a decreased gradient across the outflow obstruction and decreased obstruction. So if the obstruction is relieved, you will see that in the pathology section with the diagram. But remember, if the obstruction is relieved to some extent, that decrease in the obstruction will decrease the gradient across the outflow obstruction and resultantly will get a softening of the hypertrophic cardiomyopathy murmur. The mitral valve collapse because of increased left ventricular size, decreased left ventricular prolapse. That is also an important thing, that firstly, when we are saying that the if we talk about, okay, so let me draw a picture again. So suppose that this is the previous picture. This is a contracted heart. This is a smaller heart. So when the heart is small and the walls are close together, there is an increased propensity for the free mitral valve to move upward, right? And if the heart becomes wide, like this wide, so the leaflets will be taut. They will be stretched, and there is a decreased propensity for the leaflet, the degenerated leaflet to move upward. So when the walls are like distant, so the distance of the wall causes the leaflets to stretch, and that is why they are not prolapsed into the atria. That is also a good reason. So I guess this is a better reason than the previously described reason. So remember this one. So there is a decreased leaflet prolapse because of increase in the left ventricular size. Now there is a hand grip maneuver. If you grip the hand of the patient, or we do the hand grip maneuver, there is increase in the afterload. Why so? Because we are increasing the total peripheral resistance by compressing the arterioles or maybe the arteries. The blood pressure is also increased because of increase in the afterload, and the heart has to push harder, and the blood pressure is increasing. And thirdly, increased reverse flow across the valve. The reverse flow across the valve is increased. What is the reverse flow across the valve? The reverse flow across the valve is increased. Okay, what does that mean? I have to see that reverse flow across the valve. Okay, I don't know what valve they are talking about in particular, but they will be increasing the reverse flow across the valve. Okay, so the murmurs, it is similar to that, like squatting and hand grip are similar in the sense that they will also cause an exaggeration of the aortic regurgitation, mitral regurgitation, and VSD. So suppose that this is the valve, suppose this is the mitral valve, and the normal flow is towards from the atria to the ventricle, and the reverse flow will be from the ventricle to the atria, stuff like that. Okay, maybe it's like that. So aortic regurgitation, mitral regurgitation, and ventricular septal defects, they will be exaggerated murmurs in a case of hand grip, and hypertrophic cardiomyopathy murmur will be decreased because of increased left ventricular volume, and aortic stenosis murmur will also be decreased because of decreased transvalvular pressure gradient, because when the pressure gradient is decreased, the left ventricle is having increased pressure, and the difference between the aortic and the left ventricular pressure is decreased. So the stenotic aortic valve can open more easily, and the blood can enter that. Yeah. Now we'll talk about Valsalva maneuver. Bear down as if moving the bowels. Okay. Phase 1, for the few seconds, increase thoracic pressure, decrease venous return, compresses on the veins, and increase the right atrial pressure. Okay. Transient rise in the aortic pressure because of compression, and decrease heart rate and AV nodal conduction baroreceptors. Okay. So in the first phase of Valsalva maneuver, we're going to talk about everything. No, only the Valsalva maneuver. So when we are doing the Valsalva maneuver, in the first strain phase, when the thoracic pressure is increased, and when the thoracic pressure is increased, the venous return is decreased, that is compression of the veins and increase the right atrial pressure. There will be a transient rise in the aortic pressure, that is called compression, and decreased heart rate and AV nodal conduction, that is baroreceptor, because the baroreceptor will sense the increase in the thoracic pressure and they will send a stimuli to the brain, and resultantly the AV node will be inhibited by the parasympathetic supply, and decreased heart rate and AV nodal conduction will be there in the first phase. In the phase 2, the relaxation phase, the preload is decreased and the cardiac output is also decreased because of the decrease in the preload. There is an increase in the heart rate and AV nodal conduction because of the same baroreceptors, because now they will sense the decrease in the pressure in the inside of thoracic cavity and also in the carotid sinuses or the aortic arches. So resultantly they will send the stimulus to the brain to activate the sympathetic nervous system, and that will cause an increase in the heart rate and also the AV nodal conduction system. What is heart murmurs? Heart murmurs can either be systolic or diastolic or continuous. Systolic murmurs include aortic stenosis, mitral regurgitation, tricuspid regurgitation, mitral valve prolapse, and VSD. So you may also add pulmonic stenosis in that. So systolic murmur include aortic stenosis, pulmonic stenosis, and mitral regurgitation, tricuspid regurgitation, and mitral valve prolapse and ventricular septal defect. The diastolic murmurs are aortic regurgitation and the mitral stenosis. Okay, the continuous murmur is only one, that is called as patent ductus arteriosus murmur, and that is a machine-like murmur that will radiate to the back. Now we'll talk about the systolic murmurs, which are first one is aortic stenosis. It is the crescendo decrescendo murmur. Never forget this line because they will always tell you, either they will give you the statement crescendo decrescendo, or they will give you a visual like that, or in the worst case scenario they will give you a sound that will be increasing and decreasing in intensity. That is crescendo decrescendo murmur. So crescendo decrescendo systolic ejection murmur has systolic ejection murmur and soft S2 ejection click may be present. A soft S2 ejection click and systolic crescendo decrescendo murmur is present. The loudest at heart base and radiates to the carotids. It is very important that the aortic stenosis murmur is radiating to the carotids. The radiations are important. If we talk about aortic stenosis, we will talk about radiations to the carotids. If we talk about the mitral regurgitation, there will be radiation to the axilla. If we talk about PDA, patent ductus arteriosus, the radiation will be towards back. Same is true for the coarctation of aorta. We'll see the each murmur on the respective topic, but for right now remember that the aortic stenosis murmur is radiating to the carotids. The left ventricle is increased. The left ventricle aortic pressure intensely. Okay, so the left ventricular pressure goes way higher than the aortic pressure during the systole because of the aortic stenosis. If there is aortic valve that is stenosed, the left ventricle has to push very hard on to push the blood into the aorta. There was a picture. Just give me a second. I guess over here that was the picture. So here you can see that this is the aortic pressure. Normally the ventricular pressure overlies or overlaps this aortic pressure, but for the case of aortic stenosis, the ventricle has to push very harder and go way beyond the aortic pressure to push the ample amount of blood into the aorta to maintain the cardiac output. So here you can see the ventricular pressure is way higher than the aortic pressure. Now let's come back to our discussion over here. So here you can see that yeah, so left ventricular pressure will be way higher than the aortic pressure during systole. Pulses parvus et tardus. Pulses are weak and with a delayed peak. So pulses are weak because why so? The pulses are why the pulses are weak because the aortic valve is stenosed and there is decreased amount of the blood that is entering the aorta per minute. You may remember it like that because when the blood is moving slowly into the aorta, resultantly the pulses will be weak and the peak will be delayed because there is a slow entry of the blood into the this thing, that what do you call that, into the aorta. Okay, so can lead to syncope, angina and dyspnea. It is very sad. So when you do the exertion, the patient can have syncope, angina and dyspnea, most commonly due to the age related calcification in the older patient more than 60 years of age, or in younger patient with the early onset calcification of the bicuspid aortic valve. For example, the patient with the Turner syndrome have the bicuspid aortic valve and they can have the calcification early on in the life, like maybe in the early 40s or in the 30s in the worst case scenario maybe. So severe disease findings: late peaking murmur, slow flow across the aortic stenotic valve. So when the flow is slow, so the peak will be like close to the S2. Peak will come over here, so it will peak like that and then come down. So the slow peaking murmur because of slow flow across the stenotic valve, soft or quiet S2. S2 may be attenuated. It may be finished. It will be soft or quiet S2. Stiff valve cannot slam shut. Why will the S2 be absent? Because the S2 heart sound was heard due to the shutting of the aortic valve, and if the aortic valve cannot slam shut, so resultantly the softening or the quietening of the S2 heart sound is seen. Then pulses parvus et tardus, weak and small carotid pulses. Delayed carotid upstroke because the blood is entering slowly into the aorta, then same pattern is also followed into the carotids because carotids are the branches of aorta. Uworld point about the aortic stenosis: aortic stenosis early can cause diastolic dysfunction and hypertrophy, then late can cause systolic dysfunction and left ventricular failure. So the concept of diastolic dysfunction is that the heart cannot fill the blood properly. The diastole is impaired. The diastole means the filling of the blood. So if the diastole is impaired, this means that suppose this is the heart, and because of the aortic stenosis, the wall of the ventricle has become so thickened and so stiff that this wall cannot relax properly when it comes to the diastole. So there will be a diastolic defect initially, and in the long run, if the aortic stenosis is not cured, so this ventricular wall becomes failed and that stops contracting, and that will become a systolic failure, systolic dysfunction of the left ventricle and left ventricular failure in the long run. Okay, the Uworld point is patient with the aortic stenosis then develop atrial fibrillation, sudden onset acute heart failure, pulmonary edema and hypotension. What's that? The aortic stenosis develop atrial fibrillation. Okay, sudden onset of acute. So the patient of aortic stenosis develop atrial fibrillation. sudden onset of acute heart failure that will result in pulmonary edema and hypotension, cause sudden loss of left ventricular preload. Okay, explanation. Acute atrial fibrillation most likely precipitated sudden heart failure in chronic aortic stenosis, as atrial fibrillation leads to loss of atrial systolic click, decreased left ventricular preload, decreased left ventricular and diastolic volume, decreased cardiac output as the aortic stenosis then caused concentric left ventricular hypertrophy, which worsens the case. So they are saying that the person who is having aortic stenosis now is having atrial fibrillation, so that will result in acute heart failure, and the acute heart failure will result because already there was a decreased outflow of the heart. On top of that, there is atrial fibrillation, and the heart and the left ventricular and diastolic volume is decreased further. And due to the further decrease in the left ventricular and diastolic volume, the cardiac output decreased so much that there is hypotension. On top of that, there will be pulmonary edema because the blood flow from the lungs to the atria cannot be pumped into the ventricle properly, so that will start pulling into the lungs, and that will cause pulmonary edema. So sudden loss of the left ventricular preload. Explanation: acute atrial fibrillation most likely precipitates a sudden heart failure in the chronic aortic stenosis, as atrial fibrillation will lead to the loss of atrial systolic click that decreases the left ventricular preload. Okay, that decreases the left ventricular and diastolic volume and ultimately decrease cardiac output, as the aortic stenosis that cause the concentric left ventricular hypertrophy, which worsens the case. Uworld point is hollow systolic murmur. Remember that the atrial fibrillation in the normal or the healthy person may be asymptomatic. Okay, I know that sounds weird, but it can be asymptomatic in a sense that because the atria is pumping only a very small, the contraction of the atria is pushing a very small proportion of the blood into the ventricles. The rest of the blood is coming by the passive diffusion, right? And that's the point. But in the heart that is already diastolically compromised, there is already diastolic compromise because of the thickening of the wall. On top of that, the atria are not contracting, so in that heart there is a significant decrease in the left ventricular and diastolic volume with atrial fibrillation, and those people can have a sudden or acute heart failure with atrial fibrillation. Okay, then you will point about hollow systolic murmur. There is in the mitral regurgitation, tricuspid regurgitation, and VSD ventricular septal defect. So these are three conditions in which we find hollow systolic murmur. So let me remove the clutter and we see what is written over here. Hemodynamic of severe aortic stenosis. Number one, there is severe stenosis. Severe stenosis will impair the left ventricular output. The higher systolic pressure causes the left ventricular hypertrophy. Okay, and atrial contraction necessary for the filling of the stiffened left ventricle. Now we need the contraction for filling of the stiffened left ventricle because it cannot allow passive filling to a great extent. So that is why we require the atrial contraction, and in case of atrial fibrillation, if the atrial contraction is gone, so there can be precipitation of acute heart failure. Now let's come back. Okay. Mitral or tricuspid regurgitation, hollow systolic high-pitched blowing murmur will be heard. Mitral, loud at the apex and radiates towards the axilla. Mitral regurgitation is often due to ischemic heart disease, post-myocardial infarction, mitral valve collapse, and left ventricular dilation. The tricuspid regurgitation, loudest at the tricuspid area. The tricuspid regurgitation commonly caused by the right ventricular dilation. If the right ventricle has dilated because of maybe systolic heart failure or something, maybe dilated cardiomyopathy, so if the ventricular size is increased, the cusp of the tricuspid valve will not be tethering with each other, so there is an opening between them and the blood can flow in a retrograde fashion, or the reverse flow across the valve can be seen. So tricuspid, loudest at the tricuspid area, and tricuspid regurgitation commonly caused by the right ventricular dilation, while the mitral regurgitation is often caused because of the ischemic heart disease like post-MI, mitral valve collapse, or left ventricular dilation. Okay, rheumatic fever and infective endocarditis can cause either mitral regurgitation or tricuspid regurgitation. In mitral regurgitation, what is best indicator of severity of the problem? The presence of an audible S3 in the mitral regurgitation. The best indicator of the severity of the problem is the presence of an audible S3, not the hollow systolic murmur intensity, as the latter does not correlate well with the regurgitant volume but correlate with the effective regurgitant orifice. Note S4, as the mitral regurgitation plus S4 is end-stage decompensation of the severe mitral regurgitation or the left ventricular failure. However, many patients with a severe mitral regurgitation do not have developed left ventricular failure. So remember this thing, that the mitral regurgitation intensity or the severity of the problem is indicated by the S3 heart sound. Okay, not S4, because for the person with mitral regurgitation to reach the S4 heart sound, it means that the left ventricle has undergone failure, and that failure or the decompensated or severe mitral regurgitation can be seen, and that is a rare finding in the case of mitral regurgitation. and the murmur intensity is basically a measure of how the patent the orifice is, the the orifice of the regurgitant valve, how patent the orifice is. That is the measure of the hollow systolic murmur. Does not correlate well with the regurgitant volume, but correlate well with the effective regurgitant orifice. Now there is a case that there is a person having hypertension plus S3 plus hollow systolic murmur over the apex, but the murmur and the S3 disappeared after the diuretics and vasodilators. So what is the diagnosis? It is functional mitral regurgitation. Oh, that is a functional mitral regurgitation, which means that there is no problem with the mitral valve. The problem is that there is volume overload, and due to the volume overload, the left ventricle is expanded so much that the cusp of the mitral valve are not coming close to each other. That is why there is a functional sort of mitral regurgitation. Okay, that's cool. Okay, which is caused by either transient hemodynamic factor causing the left ventricular dilation. Acute left ventricular dilation can separate otherwise normal mitral valve, or if there is pulmonary muscle ischemia. So due to the ischemia of the pulmonary muscle, not pulmonary, sorry, due to the ischemia of the papillary muscle is holding the mitral valve in place. If the papillary muscle undergoes ischemia, the papillary muscle undergoes necrosis, it can rupture, and due to the rupture of the papillary muscle, the mitral valve can prolapse, or you may say it can become regurgitant. Forward to regurgitant flow ratio. In mitral regurgitation, some blood is pumped forward through the aortic valve, forward stroke volume, while some blood is forced backward through the incompetent valve, that is called as the regurgitant stroke volume. So in the mitral valve, some blood is going forward into the aorta, while some is coming back into the atrium. So that the one that is passing through the aortic valve, that is the forward stroke volume, and the one that is coming to the atrium by the mitral valve, that is called as the regurgitant stroke volume. It determines the left ventricular afterload in the patient with a mitral regurgitation. Decreasing afterload will increase the forward flow while reducing the regurgitant flow. Now, if we decrease the afterload by some mechanism, we cause a vasodilation or some arterial dilation specifically. So if we cause the vasodilation in the arteries, so that will cause a decrease in the afterload, and the blood will be pumped more easily into the aorta than to the atrium. Okay, and increase in the left ventricular end diastolic volume can contribute to worsen the mitral regurgitation when the degree of regurgitation is dependent on the left ventricular size. For example, in the dilated cardiomyopathy. Now, if you are increasing the left ventricular end diastolic volume, like by increasing the venoconstriction, and the venous return is enhanced, and now the left ventricle is having more amount of blood entering into that. So this can worsen the mitral regurgitation because of the fact that suppose the person had mitral regurgitation because of dilated cardiomyopathy, and the dilated cardiomyopathy states that the left ventricular size is increased and the mitral valves are not coming close to each other. On top of that, you increase the this thing that we call you increase the preload, you increase the volume in the left ventricular and diastolic volume, you increase the left ventricular and diastolic volume. So now the ventricles have grown further apart, and they will also pull the cusp of the mitral valve apart from each other, and when they do so, the mitral regurgitation murmur is intensified, that becomes worsened. Okay, so the left ventricular and diastolic volume can contribute to worsen the mitral regurgitation when the degree of regurgitation is dependent on the left ventricular size. For example, in the dilated cardiomyopathy, here you can see the mitral regurgitation, and in the picture, mitral regurgitation with the afterload reduction can be seen. Okay, if we reduce the afterload, so there is a decreased amount of blood that is going back to the atrium, and an increased amount of blood that is coming to the aorta and down to the systemic circulation. Mitral valve prolapse, late systolic crescendo murmur. Now the late systolic crescendo murmur, it's not crescendo, decrescendo. The mitral valve prolapse murmur is only crescendo murmur, that is called as late systolic crescendo murmur with mid systolic click. So this is mid systolic click with a late systolic crescendo murmur. Mid-systolic click due to the sudden tensing of the coda tendini. Okay, so when the mitral valve, okay, suppose in the systole, this is the ventricle, and on top of that we have the mitral valve, and this looks something like that, and the mitral valves are connected in position by the coda tendini by the papillary muscle. It looks something like that. So let's make one. So this is the papillary muscle and having the coda tendini. Now when the ventricle is contracting, due to the contraction of the ventricle, this starts moving upward. The damaged mitral valve, the damaged cusp of the mitral valve starts protruding into the atrium. If it is moving upward into the atrium, the coda tendini will be the papillary muscle is stretched, and that causes the sudden tensing of the coda tendini. If the papillary muscle is being contracted, so there will be sudden tensing of the coda tendini, and that sudden tensing of the coda tendini will give us the mid-systolic click. And after that, we have this crescendo murmur. Okay. Most frequent valvular lesion, it is the most frequent valvular lesion, best heard over the apex, because all the mitral valve problems or the mitral valve murmurs are best heard over the apex. Loudest just before S2, usually benign, can predispose to infective endocarditis. because when the valve cusps are moving over each other, there is a friction between the two cusps, and that will cause a tearing or friction over the mitral valve, and that will cause damage to the endothelium of the valve, and the damage to the endothelium can precipitate endocarditis. Okay, infective endocarditis can develop due to the growth of the bacteria over there. It can caused by the myxomatous degeneration, primary or secondary connective tissue diseases such as the Marfan or Ehlers-Danlos syndrome, rheumatic fever, or chordae rupture. Okay, now moving forward to the ventricular septal defect. It is a holosystolic, harsh sounding murmur, loudest in the tricuspid area, because now we are talking about the VSD. So the VSD, okay, there is an analogy which you can create for the VSD. Suppose this is the heart, like this. Suppose this is the heart, and then we have this four chambers of the heart. In the case of ventricular septal defect, there is more blood coming from the left ventricle into the right ventricle. So the increased amount of the blood in the right ventricle is giving strain to the tricuspid valve that is located over that. Right? So there will be increased bulging of the tricuspid valve into the artery, and that may also become regurgitant in the long run. Remember that, because that can happen. So holosystolic heart sounding, by the way, the murmur is not because of tricuspid pathology. The murmur is because of flowing of the blood through this septal defect. Holosystolic heart sounding murmur, loudest in the tricuspid area, and you can hear it like that. So there is a holosystolic murmur which looks something like that. The diastolic murmur, aortic regurgitation. Now we'll talk about the diastolic murmur. We are done with the systolic murmur, which were like these were the systolic murmurs. The first systolic murmur was aortic stenosis, then we did the mitral tricuspid regurgitation, and then we did mitral valve prolapse and the ventricular septal defect. Now we're going to the diastolic murmur, which are, first one is aortic regurgitation. The aortic regurgitation, high pitched, blowing. Early diastolic decrescendo murmur. So it is the decrescendo murmur. Very first thing that you must remember that it is a decrescendo murmur. Second thing, it is a diastolic murmur, and third thing, it is blowing and high pitched murmur. The long diastolic murmur, it is a long diastolic murmur, hyperdynamic pulse. Okay, so there will be a long diastolic murmur that will be heard throughout the diastole. On top of that, there will be a hyperdynamic pulse, head bobbing with severe and chronic. Okay, so if it is severe and chronic, so the person may also develop head bobbing. So there will be movement of the head with each heartbeat, that is called as head bobbing movement. The pulse pressure will be widened. Why so? We have seen that in the aortic regurgitation as well. Suppose this is the aorta. The left ventricle, okay, this is a very bad looking aorta. So this is aorta, something like that, and the left ventricle is located below that. So if the left ventricle is pushing the blood into the aorta and the blood pressure is like 120, suppose it is higher, but suppose it is 120. On the diastole, when the cusps were supposed to close, they didn't close, and the blood started moving back into the left ventricle. And when it is coming back into the left ventricle, the aortic pressure, instead of being 80, it drops down all the way to 50 or maybe even lower. So now if you measure the pulse pressure between these two things, it comes out to be like 70. Normally it should be 40, but now it is 70. And secondly, because the diastolic blood pressure is decreased, the sympathetic and the sympathetic activation and the RAS activation will cause the systolic pressure to be increased further. It will become something like 140. So now this pulse pressure has come all the way to 90. The pulse pressure is widened. The widened pulse pressure will be seen. On top of that, if you draw a graph of the aortic pressure curve, so you will not see a dicrotic notch. Okay, so often due to the aortic root dilation, okay, it is often seen due to the aortic root dilation, the bicuspid aortic valve that is seen with the Turner syndrome, and the endocarditis and the rheumatic fever, progression to the heart failure. So the aortic regurgitation may progress to the heart failure. Okay, remember that every kind of a murmur is a red flag, because any kind of murmur means that there is some ongoing pathology inside the heart, and in the long run, in the very long run, it may develop heart failure as well. So a murmur best heard when the patient sits up and leans forward. This position is very important. So which murmur is best heard when the patient is sitting up and leaning forward? That is aortic regurgitation. Uworld point, in aortic regurgitation, what maintains the cardiac output? That is increased left ventricular preload and eccentric left ventricular hypertrophy. So in the aortic regurgitation, when the blood is coming back, so because of this blood coming back, there will be eccentric hypertrophy because of the volume overload. Because whenever there is volume overload alone, there will be eccentric hypertrophy, and when there is pressure overload, we find concentric hypertrophy. So when there is volume overload because of aortic regurgitation, there will be eccentric left ventricular hypertrophy, and that maintains the cardiac output. On top of that, there is increased left ventricular preload. How come? The blood that was supposed to be in aorta is now present inside the ventricles. So the blood that is coming back will cause an increased stretch on the ventricular walls, and that increased stretch caused by the increased preload inside the left ventricle will cause the ventricle to contract harder and pump more amount of the blood into the aorta. So that thing is seen over here, the increased left ventricular preload and the eccentric left ventricular hypertrophy will maintain the cardiac output. Moving forward to the mitral stenosis. delayed. So the mitral stenosis murmur, the murmur of the mitral stenosis is the delayed rumbling mid to late diastolic murmur, follows opening snap, okay, due to the abrupt halt in the leaflet motion in the diastole. Firstly, there is delayed rumbling murmur mid to late diastole. Secondly, there will be an opening snap. Opening snap is due to the abrupt halt in the leaflet motion in the diastole after rapid opening due to the fusion at the leaflet tips. During the diastole, after rapid opening due to the fusion at the leaflet tips. Okay, so S2 heart sound, S2 heart sound is heard because of the aortic valve flow here. Now in this part, since we are talking about the mitral stenosis, you can think of it like these two valve cusps are strongly adherent to each other. When the atria is contracting, or when there is increased amount of the preload in the left atrium, when that needs to be pumped into the ventricle, so these cusps are firstly they resist the opening, and when they open at last, so there is an opening snap like movement, a snap like sound that is heard after the rapid opening due to the fusion of the leaf. Okay, fusion at the leaflet tips, the tips are fused together, and when they open, so there is an opening snap that is heard due to the abrupt halt in the leaflet motion at the diastole. Decreased interval between S2 and opening snap, S2 and opening snap, if there is a decreased interval between both of them, it correlates with increased severity. Okay, higher left atrial pressure decreases the time to opening snap. Okay, so what is the measure of intensity of the mitral stenosis or severity of the mitral stenosis? It is decreased interval between the S2 sound, this S2 sound, and the opening snap. If the interval between both of them is increased, it determines increased severity. Why so? Because it means that there is high left atrial pressure, and that high left atrial pressure is decreasing the time to opening snap. The left atrial pressure will be way higher than the left ventricular pressure during the diastole. Okay. Often a late and highly specific sequela of the rheumatic fever. Yes, the chronic rheumatic fever can cause mitral stenosis, while the acute rheumatic fever will cause mitral regurgitation. Remember that. Chronic mitral stenosis can result in left atrial dilation. Okay, so now we remember from the anatomy part of these CVS sessions that the left atrium is the most posterior structure of the heart that is in close or intimate relationship with the esophagus. So chronic mitral stenosis can result in the left atrial dilation that will cause dysphagia and hoarseness via the compression of the esophagus or the left recurrent laryngeal nerve. If the left recurrent laryngeal nerve is irritated, we'll find hoarseness, and if the esophagus is compressed, we'll find dysphagia, respectively. Okay, so S1 heart sound. Okay, we did that. Now, Uworld point is that in mitral stenosis, the opening snap is best heard at the mitral opening in pressure volume curve. Okay, in the mitral stenosis, the opening snap is best heard at the mitral opening in the pressure volume curve. So the mitral snap, opening snap is best heard when the mitral valve is opened. Yeah. So we saw that, I guess, over here. Whenever there was a picture like that. In the aortic stenosis, there was the mitral stenosis picture as well. Mitral regurgitation, then aortic regurgitation, then we have, I guess there was a picture of that. I'm not sure. Aortic regurgitation, mitral regurgitation, okay, there's a mitral stenosis. And when there is mitral valve opening, I guess this is the point of mitral valve opening over here. So this is the point where we hear the opening snap, the loudest opening snap. Okay, the aortic stenosis, and yeah, we're done with that. Let's come back to that point of discussion over here. Yep. So the Uworld point is that in mitral stenosis, the opening snap is best heard at the mitral opening in the pressure volume curve. There is another Uworld point that the best indicator of the mitral valve stenosis severity is the A2 to opening snap interval. The A2 in the S2 sound, and to be very specific, the A2 component of the S2 sound to the opening snap interval, that is going to determine the severity of the mitral stenosis. The shorter the interval, the more severe the stenosis. Not the rumble, as it depends on the patient's anatomy, and not the pre-systolic accentuation, because it indicates the left atrial contraction. So the rumble is not indicative of the severity because it depends on the patient's anatomy, and the pre-systolic accentuation, okay, as it indicates the left atrial contraction. Okay. Then we have Uworld point how to differentiate between the opening snap and the mitral stenosis and splitting of the S2. So how do we differentiate between the splitting of S2 and the opening snap and mitral stenosis? Because here you can see there is a split, right? And the similar split is also seen on inspiration. So splitting will be increased with inspiration, and opening snap will be increased with expiration. But there is another thing. If there is paradoxical, if there is the thing that we call, if there is paradoxical splitting, so this is page number 838. Yeah. So they say that the opening snap and S2 sound can be differentiated the splitting increases with inspiration and the opening snap increases with expiration, but that is not true for the paradoxical splitting. The paradoxical splitting increases with the expiration. Where is paradoxical splitting? Okay, give me a second. The splitting was, yeah, over here. The paradoxical splitting that is seen in the aortic stenosis, the left bundle branch block. So in the case of, in these cases, the in these cases we find the splitting on expiration, and the inspiration will inhibit, or the inspiration will cause the split to be fade away. So you are also supposed to differentiate the paradoxical splitting from the mitral valve stenosis. So keep that in your differential when you are talking about a split that is exaggerated on expiration. So it can either be mitral valve stenosis, opening snap, or it can be paradoxical split with the aortic stenosis. Okay, now let's talk about the hemodynamic consequences of the mitral stenosis. We'll study this column first, and then we'll see the sequelae of that in the picture. So whenever there is stenotic mitral valve, there is increased pressure gradient between the left atrium and the left ventricle. Increased left atrial pressure and volumes. So when there is increased gradient, so the left atrial pressure and volume is definitely increasing. Increased pulmonary venous capillary wedge pressure, that will cause pulmonary hypertension, because the blood pressure inside the capillaries inside the lungs is increasing, because that blood cannot be drained into the left atrium, and ultimately there is increased right ventricular pressure and volume with eventual right and the heart failure. So this is also the reason that we say that the most common cause of right-sided heart failure is the left-sided heart failure. If the blood cannot be pumped out of the left heart, so that starts pooling, and since it is a connected system, so ultimately the pooled blood will cause the pressure increase on the right side as well, and that will result in the right heart failure ultimately. So now let's talk about increased pressure gradient between the left atrium and the left ventricle will cause severe stenosis, can decrease the left ventricular filling and the cardiac output. So because of this increased pressure gradient, a severe stenosis of the mitral valve can cause decreased left ventricular filling and ultimately a cardiac output decrease. Increase in left atrial pressure and volume, it promotes the atrial fibrillation and the mural thrombus formation. Okay, it promotes the atrial fibrillation and the mural thrombus formation. Increased pulmonary venous and capillary wedge pressure, pulmonary edema and alveolar hemorrhage will be caused by that. Pulmonary hypertension will decrease the pulmonary vascular compliance due to the vessel constriction and obliteration. Okay, so decreased pulmonary vascular compliance due to the vessel constriction and obliteration will be seen with the pulmonary hypertension. And so normally we know that pulmonary system is a high compliance system, but because of pulmonary hypertension, the pulmonary vascular compliance is decreased due to the vessel constriction and obliteration, and increased right ventricular pressure. Increased right ventricular pressure, if there is increased pressure in the right side of the heart, or the right ventricular pressure is increasing, that may ultimately result in the tricuspid regurgitation, and increased jugular venous pressure and peripheral edema because of the right sided heart failure. And there will be venous pooling, and that venous pooling will cause peripheral edema as well. Moving forward to the Uworld point, that is in mitral stenosis, the normal left ventricular diastolic pressure. So in the mitral stenosis, there is normal left ventricular diastolic pressure, but in the mitral stenosis plus increased left ventricular and diastolic pressure, suspect the presence of additional lesion. What's that? In the mitral stenosis, the left ventricular diastolic pressure is normal, because I guess the mitral valve ultimately gives way to the blood to come into the left ventricle, and we have normal left ventricular and diastolic pressure. But if there is increased increased, it must be decreased, because the filling defect is there, because the mitral valve is not giving way to the blood to enter the left ventricle. So if you find that there is mitral stenosis, and on top of that the person is having an increase in the left ventricular and diastolic pressure, so you must suspect the presence of some additional lesion. For example, the rheumatic involvement of the aortic valve typically causes combined aortic regurgitation and aortic stenosis. So the rheumatic involvement of the aortic valve will typically cause combined aortic regurgitation as well as aortic stenosis. So both of these conditions will cause left ventricular and diastolic pressure along with the mitral stenosis. Okay, infective endocarditis superimposed aortic valve deformity. So there is infective endocarditis and there is superimposed aortic valve deformity as well. Mitral stenosis plus stroke due to left atrial dilation, atrial mural thrombus. That is such a beautiful point, that when there is mitral stenosis, suppose that this is the atrium and there was a mitral valve associated with that, which was like this, and the right ventricle is over here. If this is stenosed, it will not give way to the blood, so the right atrium starts enlarging, and if it starts enlarging, there will be stasis of the blood, specifically in the left atrial appendage. And when there is stasis of the blood, the thrombus will be formed, and this thrombus can be dislodged from here, and it can come into the left ventricle when the mitral valve opens, and then from the aorta it can go to the systemic circulation and into the brain and result in a stroke due to the left atrial dilation and atrial mural thrombus formation. Mitral stenosis plus tricuspid regurgitation is due to the increased left atrial pressure that will cause an increase in the pulmonary capillary wedge pressure, that will cause pulmonary hypertension, and that will be felt as pulmonary vascular sclerosis, and that will decrease the compliance of the pulmonary vascular system, and the right ventricle will start dilating, and there will be a functional tricuspid regurgitation when the right ventricle is enlarged to this extent, so the tricuspid cusp will not come, will not tether with each other, and there will be functional regurgitation of the tricuspid valve. Uworld point, late diastolic murmur eliminated by the atrial fibrillation is mitral stenosis and tricuspid stenosis. Okay, so late diastolic murmur that is eliminated by the atrial fibrillation is mitral stenosis and tricuspid stenosis. A late diastolic murmur that is eliminated. Okay, a late diastolic murmur that is eliminated by the atrial fibrillation or the atrial fibrillation is mitral stenosis or the tricuspid stenosis. So why is the murmur eliminated by the atrial fibrillation? Because the murmur was there because of contraction of the atria or atrial systole. If the atria are not contracting, so resultantly the murmur is gone. The murmur will not be heard or auscultated by the stethoscope in the case of mitral or the tricuspid stenosis. Okay. Now let's talk about the continuous murmur, the only murmur that is continuous is the patent ductus arteriosus. Continuous machine-like murmur, best heard at the left infraclavicular area, loudest at S2. So it is loudest near the S2 heart sound, often due to the congenital rubella or the prematurity. The patent ductus arteriosus public display of affection are commonly annoying. Clues to diagnosis: young female, otherwise healthy, can have mitral valve prolapse. Why? Mitral valve prolapse is the major degeneration, and the young females, due to some reason, they can have an increased risk of developing the mitral valve prolapse because of some unknown reason. So these are the clues of diagnosis. If the woman is there, if there is young female who is otherwise healthy and having a murmur, so that can be mitral valve prolapse. If there is healthy young athlete and syncope or maybe even death, that is hypertrophic cardiomyopathy. If there is immigrant or pregnant, so that can be mitral stenosis. What? In the immigrant mothers, in the immigrant patients, there will be mitral stenosis. Why will there be mitral stenosis? I guess because of the rheumatic fever, or in the pregnancy there is mitral stenosis because of some reason. Okay. Then IV drug abuser tricuspid regurgitation, that is very important. Staphylococcus aureus in the IV drug abusers will cause the tricuspid regurgitation, the right-sided regurgitation. Then we have Turner syndrome or the aortic coarctation that causes bicuspid aortic valve, early stenosis and aortic regurgitation, and Marfan syndrome is also associated with the mitral valve prolapse. Moving forward, we have systolic clicks. So the ejection click is seen in the bicuspid aortic valve. It is in the early systole before the carotid pulse, and bicuspid aortic valve causes the ejection click over here. The non-ejection click is seen in the mitral valve prolapse. Okay, that is opening snap of the mitral valve. That is mid-systolic click. That is not opening snap. It is mid-systolic click. Yeah, it is non-ejection click late in the systole after the carotid pulse. So if the click is after the carotid pulse, that is this thing mitral valve prolapse. And if there is early systolic click, that is before the carotid pulse, so that is bicuspid aortic valve. Okay. Moving forward to the cardiac murmur. So this is a table from the Uworld, and that is very important because they are they have tabulated the systolic, diastolic, and the continuous murmur separately. Now let's talk about them one by one. The systolic murmur are aortic stenosis, mitral regurgitation, hypertrophic cardiomyopathy, mitral valve prolapse, and atrial septal defect. Atrial septal defect and the ventricular septal defect. Okay, so aortic stenosis murmur is, it is a crescendo decrescendo murmur at the right upper sternal border in the A2 area. Is there a picture of that? No, there is no picture. So it is in the right upper sternal border in the A2 area, A2 soft and delay. Also A2 is the S2 heart sound. We know it has two components. The S2 heart sound has an A2 component and a P2 component. So the S2 component is either soft or delayed for the aortic stenosis. So the A2 component, this component will be soft or delayed, and we have a crescendo decrescendo type of a murmur which can be seen, a crescendo and then decrescendo murmur. Now there is mitral regurgitation. So the mitral regurgitation is over here. Mitral regurgitation produces a hollow systolic murmur at the apex, and that radiates to the axilla. It is very important to remember these radiations, that the murmur of mitral regurgitation is radiating to the axilla. So here you can see we have S1, S2 heart sound, and the hollow systolic murmur is present, and this murmur will be radiating to the axilla, and it is best heard at the mitral area, that is at the apex. Now talking about the hypertrophic cardiomyopathy. So hypertrophic cardiomyopathy murmur is also a crescendo decrescendo murmur, but it is not hollow systolic. So it is crescendo decrescendo murmur heard at the mid left sternal border. Okay, so it is at the where is it? It is at the mid left sternal border, or you may say that it is the A2 area, A2 auscultatory area on the chest wall. Okay, so mid left sternal border, that is the hypertrophic cardiomyopathy murmur area. Then the mitral valve prolapse. will find a mid-systolic click in this thing, and that mid-systolic click will be a late mid-systolic click after the carotid pulse. Okay, so that mid-systolic click will be auscultated, followed by the late systolic murmur. What about the atrial septal defect? In the case of atrial septal defect, we'll find a mid-systolic murmur with wide and fixed splitting. So here you can find a mid-systolic murmur. Over here it is not hollow systolic at all. It is mid-systolic murmur with wide and fixed splitting of the S2. Okay, so here you can see that the A2 and P2 have been split. There is a split in them, and that is also a fixed split, that is throughout inspiration and expiration. Then talking about the ventricular septal defect, this is the hollow systolic murmur again at the left sternal border. Ventricular septal defect, VST murmur. Okay, it is also the left sternal border. Then let's talk about the diastolic murmur. The aortic regurgitation is the diastolic murmur. It is of the decrescendo type. So decrescendo at the left upper sternal border, the valvular. Okay, so left upper sternal border. So it is in the A1 area. Okay, the valvular variety of the aortic regurgitation is best heard at the left upper sternal border. Is the left upper sternal border? It must be right upper sternal border. It is aortic regurgitation. Right upper sternal border. Okay, I'm sorry. The valvular variety is heard best at the left upper sternal border, while the right upper sternal border shows the aortic root dilation type of decrease of the aortic regurgitation. Like if it is because of the aortic root dilation, then that type of murmur is best heard at the right upper sternal border. But if it is because of the valvular pathology, that is heard at the A2 area on the left upper sternal border. Then mitral stenosis, opening snap. It is the diastolic murmur. There is opening snap followed by the mid diastolic rumble. This thing with a pre-systolic accentuation. So this thing is called as a pre-systolic accentuation. Okay. Then the continuous murmur, patent rectus arteriosus. It is the continuous murmur, machine-like murmur in the interscapular region posteriorly. So the footnote is that pulmonic and tricuspid valve murmur are similar in character to their aortic and the mitral valve counterparts, but with different location on the optimal auscultation. The murmur can be further differentiated from their left-sided counterparts by an increase in intensity with inspiration. We have seen these maneuvers. So the aortic stenosis murmur. So let's talk about the pulmonic stenosis murmur. That will also be a crescendo decrescendo murmur. If we talk about mitral regurgitation, it is a hollow systolic. So the tricuspid regurgitation is also a hollow systolic murmur. And same is true for the other things. So we'll keep the section till here, and we'll continue for the myocardial action potential in the next session. Until then, Allah Hafiz, and take care.